So good afternoon. I'm Allison Huang, and for those of you I haven't met, I'm an internal medicine physician, clinical epidemiologist, clinical trialist at UCSF. My own research focuses on improving evaluation and management of genitourinary symptoms in older women in the community. I want to thank the planning committee for asking me to kick off this session by talking about knowledge gaps and the burden of non-cancerous GU conditions. Now, I realize this is a very broad topic, and also that while all of us at Caribou want to advance the science of GU diseases, not all of us are specifically interested in the burden of GU diseases. For those of you pursuing more mechanistic research, maybe the burden of GU disease takes up only a few lines in the background section of your grant applications. So today, I don't want to take up a lot of precious time talking about the latest estimates of the general prevalence of GU conditions or the economic cost of these conditions. Instead, I want to lead us in thinking a little about specific types of knowledge gaps in the burden of GU disease that can present important obstacles to clinical or public health management. And in the interest of time, I'll bring up a few examples from my own research area, which is lower urinary tract symptoms in older women. But I'm sure that many of you can think of other similar and important gaps for other types of GU diseases or for other populations relevant to you. So first, what do we mean by the burden of GU conditions? 2 years ago, the NIDDK convened a workshop leading to creation of a conceptual framework for understanding this burden, summarized in this figure. So the top half of the figure focuses on the direct impact of conditions on the functioning and well-being of affected individuals, also on other people and organizations and communities surrounding these individuals. And then the bottom portion focuses on bidirectional associations between GU diseases and biological systems. Because even though conditions like chronic prostatitis or nephrolithiasis can first develop due to underlying biological dysfunction, once they develop, they can exert new biological health effects, sometimes due to the very interventions we use to try to treat them. Now, this workshop also produced a model for thinking about specific inflection points that present unique opportunities for shaping the course of GU conditions. That is, sensitive time periods across a life course when specific actions or inactions can have a particularly important effect on subsequent disease impact. So this includes inflection points in the prevention phase of disease, when early pathophysiologic changes may have occurred, but overt GU symptoms haven't yet developed. And then in the management phase, after GU symptoms have developed, but we may be able to mitigate or resolve symptoms by recognizing and intervening on them. And the message is that by focusing our research on these kinds of inflection points, we have the greatest chance of reducing the downstream burdens of disease. So what do we already know about the burden of GU diseases? Well, we have pretty robust data on the prevalence and in some cases incidence of many GU conditions, at least in mainstream demographic groups. We also have evidence of the impact of these conditions on the day-to-day feelings and activities and relationships of the individuals who have them. We also have some estimates of the economic costs incurred by clinical visits and treatments, hospitalizations, lost work productivity. But there are many specific and important gaps. For example, within my own area of research on lower urinary tract symptoms in older women, most of the cohort studies that have described the individual level burden of symptoms like urinary incontinence have recruited women who are English speaking, cognitively intact, don't belong to racial ethnic groups that are underrepresented by medical research. Or if they've recruited minority women, those women aren't representative of others from their racial or ethnic background. Or we don't know if the self-report measures that we use to characterize impacts are even appropriate or reliable or valid across different cultural groups. So as an example, some of my own early research on the impact of incontinence relied on the Incontinence Impact Questionnaire. Many of you know this IIQ is one of the first psychometrically validated self-report measures of the impact of incontinence. The formative research to develop the IQ was conducted almost entirely among non-Latina white women. Some of the references may not be that relevant to other cultural groups. Using standard literacy metrics, some of the items aren't that understandable for women with less than a college education. And so when Stephen Van and I reported on differences in the impact of incontinence between Latina and non-Latina women based on this measure, it wasn't clear if these reflected true differences in the experience of those groups or just differences in how the instrument performed across groups. And also whether the instrument was really measuring impact or burden in ways that were meaningful from the perspective of these women. Now, another major gap involves the burden of GU conditions on people, organizations, or communities beyond the level of the individual patient. This is particularly important when treatment choices and outcomes are shaped by people other than the patient, like family members of patients. So for example, in my research on aging women who not only have urinary symptoms like incontinence, but also other chronic and disabling conditions like cognitive impairment, we know that development of incontinence is a key tipping point, aka inflection point, that results in older adults living in the community to be institutionalized. But we have only a limited understanding of the disease-specific burden on caregivers who are the main stopgap against institutionalization. Almost all self-report measures for incontinence are designed to be completed by cognitively intact patients, not caregivers. In clinical trials, the typical outcome measure is reduction in incontinence episodes per day, rather than social or psychological outcomes that may be more aligned with the priorities of caregivers. Few clinical trials have even enrolled cognitively impaired older adults or those who depend on caregivers in the community. In qualitative research that I and others have conducted among caregivers for older adults with both urinary incontinence and cognitive impairment, trying to create storyboards and instructional videos addressing their questions and needs and knowledge gaps about incontinence, we find that usual first-line behavioral management strategies recommended by clinicians can be difficult for caregivers to implement. Caregivers may have different perceptions of the benefit to risk ratio of clinical treatments when they're simultaneously trying to respond to the complex needs of their cognitively impaired loved ones. And the day-to-day quality of life of caregivers can be influenced more by their ability to get access to containment products than clinical treatments. And then there are many remaining questions about how GU conditions influence the course of other chronic conditions. So let's just take the example of overlapping nocturia and insomnia among older women in the community. Many older women report sleep disturbance associated with waking up at night and missing the bathroom. But older patients can develop poor interrupted sleep for so many other reasons: age-related changes in their sleep continuity, changes in activity or time spent in bed, exogenous factors like medication use, endogenous factors like pain and stress. Some older adults who are prone to insomnia awaken for other causes, then perceive an urge to urinate. But of course, once they get up to use the bathroom, it can worsen their already poor sleep quality by giving them a stimulus for extended waking. And so, in my own studies of women with overactive bladder, one of the challenges is to determine the degree of sleep dysfunction that's truly attributable to nocturnal urges to urinate. This has important implications for management because our approach to treatment may differ depending on whether women are experiencing sleep disruption because of nocturia, getting up to urinate at night because of poor underlying sleep quality, or both. And finally, there are important gaps in our knowledge about the burden of common clinical treatments for GU conditions across different populations. So one major concern is the lack of high quality data on the long-term safety of common medications used for lower urinary tract symptoms in older adults. Anti-muscarinic bladder medications used to treat urgency incontinence or overactive bladder have the potential to cause short-term confusion in cognitively vulnerable adults. Several observations have reported high rates of diagnosed dementia among older patients on these medications. However, the data linking anti-muscarinic therapy with dementia come primarily from retrospective analyses. There's a high likelihood of confounding from shared underlying risk factors for urinary incontinence and cognitive impairment in older adults. And so we don't really know whether older patients who start anti-muscarinic therapy in an effort to improve their bladder control may be risking even more serious functional impairment from cognitive decline. In a recent pilot randomized trial conducted by my research team in older women with either normal cognition or mild cognitive impairment, in addition to urgency incontinence, women randomly assigned to use tolterodine antimuscarinic medication or identically encapsulated mirabegron as an alternate beta-3 agonist medication. Over 2 months, women in the antimuscarinic therapy group had a worse trajectory in several cognitive function tests relative to the beta-3 agonist group. Interestingly, with regard to urinary symptoms, the average frequency of urgency incontinence and multiple other types of urinary symptoms improved more in the antimuscarinic group relative to the beta-3 agonist group. This has prompted us to design a larger, more extended, more definitive trial that, fingers crossed, we hope to launch with NIH funding very soon, so that in the future we can counsel older incontinent women better about how to weigh the potential trade-offs of treatment choices for their urinary function, for their cognitive function, and for other outcomes important to them. So in wrap up, I think we're at an exciting point in research on the burden of non-cancerous GU conditions. We can go beyond broad surveys of disease prevalence and bother or costs. We can target our work to more important inflection points in the life course to higher risk populations. We can focus on outcomes that are truly meaningful to both affected individuals and society. And of course, incorporate greater rigor into our methods to support more valid conclusions.